Thank you, Christina and Heather. Over the next 20 minutes, we're going to focus on the role of multimodality cardiovascular imaging, in particular, the complementary roles of echocardiography, cardiac CT, and cardiac MRI in the non-invasive diagnosis of apical cardiomyopathies. I have no disclosures. With respect to the outline of today's brief talk, we're going to focus on 4 key items. 1, an introduction to the various complementary imaging platforms in 2020, followed by the diseases that are associated with an apical cardiomyopathy, specifically LV non-compaction, apical hypertrophic cardiomyopathy, and then finally other apical disorders of the heart that one must consider in the differential diagnosis. In 2020, we currently have 4 complementary imaging modalities in terms of echocardiography, MUGA scan imaging, cardiac CT, and cardiac MRI, which has its own strengths and limitations, providing complementary information in our evaluation of patients with cardiovascular disease. This is a summary table that I have created that shows the various features of the 4 imaging modalities, echo, MUGA, CT, and cardiac MRI. The first feature is that of spatial resolution, which refers to how fine of a detail can you see. One can clearly identify that cardiac CT has the highest spatial resolution of 0.4 to 0.5 millimeters, which allows us to assess the coronary anatomy non-invasively using this imaging technique. Cardiac MRI has a spatial resolution of 1 to 2 millimeters, followed by echocardiography, both transthoracic and transesophageal echocardiography, which is up to 3 to 4 millimeters. Then we move on to temporal resolution, which refers to how fast of an image can you see. It's very similar to the shutter speed of your camera. You can see where the Achilles heel of MUGA, CT, and MRI is a frame rate of only 10 frames per second. Echocardiography, both 2D, with frame rates of up to 100 frames per second, and M-mode echocardiography of 1,000 to 5,000 frames per second truly is advantageous, especially with individuals who have abnormalities with their valves that are moving very quickly, where you want to see pathology such as endocarditis, that you should be using echocardiography. Then we move on to portability. One can see that as we have come over the past 30 years, echo is becoming much miniaturized as compared to MUGA, CT, and MRI. Radiation is a key element. One must note that echocardiography and cardiac MRI are not associated with any radiation exposure. However, both MUGA and cardiac CT are associated with radiation. Specifically, if you look at the number of millisieverts, MUGAs are associated with about 5 millisieverts, which equates to about 50 chest x-rays, and cardiac CT, prospective that is anywhere from 10 to 20 chest x-rays. Finally, with respect to renal impairment, one must remember that if individuals have a reduced eGFR, cardiac CT and cardiac MRI cannot be performed in these individuals if you need to administer contrast agents, as opposed to echocardiography and MUGA, where it is safe to give these procedures. With respect to echocardiography, this continues to be the workhorse of imaging in 2020. Where non-invasively one can clearly identify the LV systolic diastolic function, whether there are valvular abnormalities in the patient, as well as pericardial disease, all in one limited study. With respect to MUGA scans, they are very useful in the provision of accurate LV ejection fraction values, in particular in individuals that are receiving anthracycline-based chemotherapy in the cardio-oncology realm. However, in the setting of apical cardiomyopathies, MUGA scans have limited use. With respect to the role of cardiac CT, although it is very useful in the assessment of coronary anatomy stenosis non-invasively, there is a role of cardiac CT in individuals for the diagnosis of apical cardiomyopathy, in particular when the transthoracic echocardiographic images are suboptimal and or the patient has a contraindication to cardiac MRI. And finally, there is cardiac MRI, which non-invasively can provide us accurate assessment of LV volumes as well as ejection fraction, in particular with patients with apical cardiomyopathy. The true strength of cardiac MRI lies in its ability to non-invasively assess tissue characterization. In particular, after the administration of gadolinium agent into patients, we can image the heart 10 minutes later. In brief, if you see that the myocardium is black, that represents healthy tissue. However, if the myocardium turns white, that suggests that there may be a degree of fibrosis or scar in the patient, and this is very important in the patient population with apical cardiomyopathies, as we will see later in the current presentation. Now that we have a brief understanding of the various cardiovascular imaging platforms available to the clinician, and in particular the strengths and weaknesses of echocardiography, MUGA scan, cardiac CT, and cardiac MRI, let's focus on the most common apical cardiomyopathy that one wants to evaluate, that being LV non-compaction. Using a case-based approach, the first case is that of a 44-year-old female who has a past history significant for hypertension, elevated lipids, and a smoking history. Over the past 3 months, she noticed that she has New York Heart Association functional class 3 symptoms where she has difficulty climbing up a flight of stairs. She describes two-pillow orthopnea, new onset paroxysmal nocturnal dyspnea, and she has noticed bilateral pedal edema where it's difficult for her to put her shoes on. With respect to her vital signs, her blood pressure is 140/70, right arm. Her heart rate is 92 and regular. She does have an elevated JVP that's 6 centimeters above the sternal angle. She has normal first and second heart sounds. She does have an audible third heart sound, and there are no cardiac murmurs. When one evaluates the 12 lead EKG, there is a nonspecific interventricular conduction delay. As we review our transthoracic echocardiographic images, in particular the 4-chamber view without and with color, one can clearly see that there is increased trabeculations present at the LV apex, and in particular when we place color Doppler, there is presence of intratrabecular recesses with color that goes within these spaces. To further, when we focus on the apical 2-chamber view, again without and with color, one can clearly identify that there is increased trabeculations at the LV apex and that there is color Doppler that goes and flows within the intratrabecular recesses. As the patient had new symptoms of shortness of breath, a cardiac catheterization was performed which revealed no evidence of obstructive coronary disease involving the left side system nor the right coronary artery. And finally, a cardiac MRI was performed which revealed evidence of excessive trabeculations noted towards the LV apex, as can be seen on the current CMR images. With respect to left ventricular non-compaction, it is rare with estimated prevalence of approximately 0.2%. In terms of the embryology, it's the arrest of normal embryogenesis of both the endocardium and myocardium that leads to prominent trabeculations and deep recesses, as can be seen in the figure diagram. As echocardiologists and our sonographer partners, what does one evaluate on echocardiography for LV non-compaction? One wants to see if there is evidence of prominent ventricular trabeculations, deep intratrabecular recesses, as well as LV dilatation with reduced LV systolic function. Now, there are a number of echocardiographic criteria. We're going to focus on one by Jenny et al. That was published in 2001, where we want to see if the ratio of the non-compacted to compacted myocardial thickness is greater than 2 at end systole, see if there's trabeculations located within the mid-lateral, apical, and mid-inferior segments, and then finally, if there's evidence of color Doppler flow within deep perfused intratrabecular recesses. In addition to the Jenny et al. Criteria, this is another criteria by Stolberger and colleagues from 2004. With respect to diagnosis of LV non-compaction echocardiography, they want to see greater than 3 trabeculations protruding from the LV apex, trabeculations with same echogenicity as the myocardium with synchronous movement, perfusion of intratrabecular spaces from the LV cavity, and their ratio of non-compacted to compacted myocardial thickness was greater than 2 at end diastole. On the current slide, we have additional representative echocardiographic images here where the non-compacted to compacted myocardial ratio is greater than 2 at end systole. In addition, one can see that there's evidence of prominent trabeculations and that there is color Doppler flow within the intertrabecular spaces. In those patients with poor acoustic echocardiographic windows, one can administer contrast agents for LV opacification, as can be seen by this representative figure from Oshlin and colleagues demonstrating the hypertrabeculation towards the LV apex. Now, one must remember that there are limitations of echocardiography in the non-invasive diagnosis of LV noncompaction. This was a paper published by Coley and colleagues in the European Heart Journal in 2008, and they commented on the following three key elements. The first is that three different echo criteria, Chin et al., Jenny et al., and Stolberg et al., were derived from very small patient populations. The second is that the criteria are not validated in different ethnic groups. Up to 10% of actually healthy black controls in the study by Coley et al. Fulfilled one or more diagnostic criteria for LV noncompaction. And finally, when one sees abnormal trabeculations, you need to make sure that you don't mistake them for normal myocardial trabeculations, which is less than 3, false tendons, aberrant bands, as well as LV apical thrombi. Now, transitioning to cardiac MRI, there are two diagnostic criteria that are often referenced to. One is the Peterson et al. Criteria from 2005, where they look at the ratio of non-compacted to compacted thickness greater than 2.3 at end diastole in the horizontal long axis view, with sensitivities and specificities as labeled there. The other is diagnostic criteria by Jacques et al. From 2010, where they focused on the trabecular mass within the LV greater than 20% of total LV mass on short axis view at end diastole, and this has a sensitivity and specificity of 94%. On this slide, we can see representative cardiac MRI images where on the left, we see a 4-chamber view demonstrating the hypertrabeculation involving the lateral to apical segments. And then in the coronal view, again, we see the excessive trabeculation involving the LV cavity. As described earlier with respect to the role of gadolinium administration in cardiac MRI for tissue characterization, in individuals with LV noncompaction, if there is enhancement of the LV trabeculations, this can serve as a substrate for increased arrhythmogenesis in this patient population. In individuals who have poor echocardiographic acoustic windows or contraindications to undergo cardiac MRI, cardiac CT can be used in the non-invasive diagnosis of LV noncompaction. This study by Sidhu et al. From 2014 evaluated CT use in 8 patients with LV noncompaction and 11 individuals with non-ischemic dilated cardiomyopathy. Using the diagnostic criteria for Jenny et al. On echocardiography or the Peterson et al. Criteria on cardiac MRI, they did 64 slice CT with retrospective gating in this patient population. These are representative CT images in their patient population where one can again clearly see, in particular on the right, the ratio of the non-compacted to compacted myocardium that is suggestive of LV noncompaction. With respect to the current Venn diagram comparing normal variants and the overlap with LV noncompaction, one must remember that the disease should not be diagnosed by imaging alone. One should focus as the clinician on symptoms. Does the patient have a history of shortness of breath as well as syncope? Is there a family history of sudden cardiac death? Are there abnormal EKG findings such as T-wave inversion or left bundle branch block that make you think that this patient may have an underlying cardiomyopathy? On echocardiography, the patient may have a decrease in the lateral E prime less than 9 centimeters per second. There may be a decrease in the EF on exercise echo, as well as abnormal myocardial strain parameters. And finally, in addition to cardiac MRI, if there is evidence of late gadolinium enhancement, this may be suggestive more of LV noncompaction. Now that we have a clear idea of the various cardiovascular imaging platforms and specifically how do we diagnose LV noncompaction using echocardiography and cardiac MRI, let's focus on another apical disease, that being apical hypertrophic cardiomyopathy. In the second case, we have a 51-year-old gentleman who has a past history significant for hypertension. He has a witnessed out-of-hospital cardiac arrest and is resuscitated from ventricular fibrillation in the field. En route to the hospital and on telemetry, there's evidence of significant PVCs. On examination, his blood pressure is 140/80 in the left arm with a heart rate that's 82 and regular. His JVP is normal. He has a normal first and second heart sound with a diastolic fourth heart sound, and he has no cardiac murmurs. On this 12-lead EKG, if we focus our attention to the precordial leads between V1 to V6, we can clearly identify that there are significant T-wave inversion abnormalities present. On the current parasternal long axis view, the LV systolic function is preserved and there's clear evidence of hypertrophy that progresses towards the LV apex. On the apical two-chamber view, the LV wall thickness measures up to 16 millimeters, and if we check the ratio of the apex to posterior wall, it is greater than 1.5. With respect to apical hypertrophic cardiomyopathy, we know that HCM is an autosomal dominant disease of the myocardium caused by mutations in one of 9 genes that encode the sarcomeric proteins. With respect to apical hypertrophic cardiomyopathy, it is rare with hypertrophy that is focal localized involving the LV apex. In 1976, Sakamoto and Yamaguchi described this with giant T-wave inversions with spade-like deformity of the apex on left ventriculography. Note that apical hypertrophic cardiomyopathy represents up to 25% of the entire hypertrophic cardiomyopathy population in Japan, as opposed to only 1 to 3% in the Western world. The clinical presentation of apical hypertrophic cardiomyopathy can vary from being asymptomatic as an incidental finding to severe manifestations including sudden cardiac death, lethal ventricular arrhythmias, as well as an apical infarction. With respect to echocardiography, the diagnostic imaging that one must focus on is asymmetric LVH confined to the LV apex, an apical wall thickness that is greater than 15 millimeters, and then the ratio of the maximal apical to posterior wall thickness greater than 1.5. In the apical 4-chamber view and the apical 2-chamber view on this echocardiographic images, there is evidence of hypertrophy towards the LV apex consistent with apical hypertrophic cardiomyopathy. These are representative cardiac CT images showing again the same diagnosis of apical hypertrophic cardiomyopathy where there's significant LVH towards the apical component. And finally, on cardiac MRI, in both the vertical long axis view or 2-chamber view and the horizontal long axis view or the 4-chamber view, there is evidence of this ace of spade deformity present within the LV cavity with apical hypertrophy consistent with the diagnosis. And as previously mentioned, following the administration of gadolinium, one can characterize the tissue as can be seen on this cardiac MRI. If we focus our attention on panel D in particular with the arrows, although the myocardium should be black, which is healthy, we can see that there is evidence of white fibrosis, which increases the risk of the patient to have an arrhythmogenic substrate in this diagnosis of apical HCM. Now that we have an increased understanding of the various cardiovascular imaging platforms, how and when diagnose LV non-compaction, and then finally apical hypertrophic cardiomyopathy, what other apical impostures must one consider in the differential diagnosis of apical disease? This is an example of a linear density present within the LV apex that originates from the interventricular septum towards the lateral wall, and this is consistent with an LV apical false tendon. This is a focused apical 2-chamber view where we can clearly see a large echo-dense mass consistent with a thrombus in an individual post-myocardial infarction. This is a cardiac MRI of a patient with an LV apical thrombus, and when one looks at the gadolinium-enhanced images on the right, one can clearly identify that the mass does not enhance, which is in keeping with thrombus. On this echocardiographic images without and with contrast, this is an individual who presents with myalgias and found to have evidence of increased eosinophilic count on their blood work consistent with hypereosinophilic syndrome. And finally, this is a unique case of an individual where in echocardiography, one can appreciate that there are multiple echo-dense masses that are present within the LV apex. When we did cardiac MRI on this patient, we can see that there are multiple thrombi that are present within the LV apex, in particular involving the distal interventricular septum. On the T2 images on the left, we can see the masses that are present within the interventricular septum and lateral wall that are hyperintense and white. And when we give gadolinium to this patient, we can see that the masses do highlight. Finally, this is the representative PET scan of the individual, which shows that those masses that are present within the LV interventricular septum lateral wall do light up. And in the end, this patient was diagnosed with a peripheral malignant nerve sheath tumor that originated from the axilla that metastasized to the chest into the myocardial itself. So over the past 20 minutes, we have focused on one, the cardiovascular imaging platforms that are available to us in 2020. Second, how do we diagnose LV non-compaction using echocardiography and cardiac MRI? Third, how does one diagnose apical hypertrophic cardiomyopathy? And then finally, other apical disorders that should be considered within the differential diagnosis. At the end, the take-home message is the following. In the diagnostic workup of an apical cardiomyopathy, LV non-compaction, and apical hypertrophic cardiomyopathy are top two diagnostic entities to entertain within the differential diagnosis. One must remember that echocardiography, with contrast in particular, and cardiac MRI are the two main imaging modalities. And in the differential diagnosis of apical impostures, please do not forget false tendons, an apical thrombus, hyperesophagetic syndrome, as well as malignancy. Thank you.
Thank you so much for the opportunity to present on multimodality imaging of restrictive cardiomyopathies. I do not have any relevant disclosures. Through the next 20 minutes, I will review some of the common imaging features of restrictive cardiomyopathy, and then some of the secondary causes of restrictive cardiomyopathy and how multimodality imaging can help us identify features that are typical for diagnosis, that inform management, and that inform prognosis. The morphologic features consistent with a diagnosis of restrictive cardiomyopathy can be identified on echo, cardiac MRI, and cardiac CT. They include normal or increased LV or RV wall thickness, being deliberate to use the term wall thickness rather than hypertrophy, as many as the underlying causes are due to infiltrative or storage diseases. The increased wall thickness is often symmetric, but can be asymmetric. Ventricular size is normal, and the atria are typically enlarged. We can identify the expected hemodynamic changes in restrictive cardiomyopathy non-invasively using echo. We expect to see a restrictive filling pattern with an E to A ratio of more than 2, reduced tissue Doppler indices, and an increased E to E prime ratio. The IVC and hepatic veins are typically plethoric. Further interrogation of the hepatic vein with pulse wave Doppler identifies diastolic flow reversal during inspiration. And we can use the Rice mnemonic to remind ourselves that we expect to see the reversal in inspiration with restriction and expiration with constriction. If these common imaging features are identified, then a multimodality approach can be helpful in determining if there is a secondary cause of restrictive cardiomyopathy that can be identified. There are many causes of restrictive cardiomyopathy. There is an idiopathic form where no secondary cause is identified. There are also infiltrative disorders, storage disorders, and other causes including drugs, radiation, and eosinophilia. Tissue characterization can help us distinguish between some of these secondary causes of restrictive cardiomyopathy. So our multimodality imaging approach will focus on techniques that allow us to characterize the myocardial tissue. We'll first start by discussing cardiac amyloidosis. In both AL and ATTR amyloidosis, amyloid fibrils can deposit in the myocardium, leading to a restrictive cardiomyopathy. The joint position statement on diagnosis and management of cardiac amyloidosis, published earlier this year by the CCS and Canadian Heart Failure Society, emphasizes the use of echo and cardiac MRI to raise the suspicion of cardiac amyloidosis, and emphasizes the use of screening for plasma cell dyscrasia, technetium-99 PIP scans, and endomyocardial biopsy as more confirmatory tests for identifying cardiac amyloidosis. There are morphologic features that are classically described in association with cardiac amyloidosis, including thickened aortic and mitral valves, mitral leaflet tethering, the absence of LV dilation as depicted in this apical four-chamber view, a speckled appearance of the myocardium, although we appreciate that with harmonic imaging, even a normal myocardium can appear speckled, pericardial effusion, and thickened interatrial septum. However, these findings are not specific or sensitive for cardiac amyloidosis. Typical imaging features of cardiac amyloidosis were proposed in the 2019 consensus recommendations. On echo, they identify increased LV wall thickness more than 12 millimeters, a relative apical sparing of the global longitudinal strain ratio with a ratio value of more than 1, and greater than or equal to grade 2 diastolic dysfunction. From MRI, they include an increased LV wall thickness, global ECV of more than 0.4 or 40%, diffuse late gadolinium enhancement, and abnormal gadolinium kinetics, in addition to PET findings. The typical strain pattern in patients with cardiac amyloidosis has often been described as a cherry on top with relative sparing of the apical segments. As highlighted in this consensus recommendations, this can be quantified with the relative apical sparing of the longitudinal strain ratio, which can be calculated by dividing the average apical longitudinal strain divided by the combined average of the basal and midventricular segments, with an abnormal ratio being greater than 1. In this example, the ratio was 1.6, which is abnormal, even though this cherry looks like it might be anteriorly displaced. The sensitivity is 93%, specificity 82%, with a positive predictive value of 94% and a negative predictive value of 75%. Of the 4 features on cardiac MRI, 3 of them require the administration of gadolinium. Gadolinium is an extracellular compound. When administered to patients with normal myocardium, the gadolinium will wash in and wash out. However, if administered to patients with disrupted cell membranes, like those with acute infarction or inflammation, or patients who have areas of fibrosis or expanded extracellular volume, the gadolinium can accumulate. And if we image 7 to 10 minutes after administration of gadolinium, we will see hyperintense regions identifying areas where gadolinium has accumulated. Findings from the preparatory sequences for late gadolinium enhancement can help us identify abnormal gadolinium kinetics. Usually on these sequences, the myocardium nulls after the blood pool as visualized here. But in patients with amyloid, the myocardium actually nulls prior to the blood pool. So here you can see on image 1, the myocardium is nulled, it's hypointense, and the blood pool is hyperintense. So this is abnormal and consistent with cardiac amyloidosis. Late gadolinium enhancement can help identify patients with cardiac amyloidosis. The classic pattern is global subendocardial late gadolinium enhancement. This is an example of the classic subendocardial late gadolinium enhancement seen in a patient with cardiac amyloidosis. However, the late gadolinium enhancement can also be more patchy or even extensive and diffuse, where it's difficult to null any part of the myocardium. These patterns have a sensitivity of 85% and a specificity of 92%. The final MRI parameter is a global extracellular volume of more than 40%. MRI can be used to estimate the ECV because we know that amyloid infiltration expands the ECV and gadolinium accumulates in extracellular spaces. Furthermore, gadolinium decreases the T1 time of the myocardium, so we can compare the T1 time before and after administration of gadolinium to estimate the ECV. And we do so using this equation, which I've included to highlight that the hematocrit should be measured within 24 hours of the MRI to obtain the most accurate estimation of the ECV. There are practical issues with administering gadolinium in patients with known or suspected cardiac amyloidosis. Many of these patients have concomitant renal impairment. An eGFR of less than 30 was previously a contraindication to the administration of gadolinium-based contrast agents due to the risk of nephrogenic systemic fibrosis. However, this is now evolving. There are newer agents which are more stable and have a very low risk of nephrogenic systemic fibrosis, and this has led to revision of the recommendations from the Canadian Association of Radiologists. At present time, they suggest that newer, more stable agents such as deuterium, which is macrocyclic and ionic, can be administered to patients with an eGFR of less than 30 on a case-by-case basis, particularly where cardiac MRI is needed for clinical reasons and there's no suitable alternative test. This is site-specific, of course, and depends on the gadolinium agent at your specific center. At UCSF, we are using deuterium and are administering it to patients with severe renal dysfunction, including those on dialysis. The second issue is there have been concerns about accumulation of gadolinium, particularly in the brain, with repeated administration of gadolinium. And then, of course, it does take time to complete the protocol, and that's incredibly important as we try to ensure that all of our patients have timely access to cardiac MRI. Given some of these potential limitations, I thought it would be worthwhile to review a few additional imaging features beyond those listed in the expert consensus recommendations. The first is a ratio of the LVEF to global longitudinal strain with an abnormal cutoff of more than 4.1, having the best operating characteristics for distinguishing patients with cardiac amyloidosis from other causes of increased LV wall thickness. And while it's not currently in the expert recommendations, it may find its way there in the future. Patients with cardiac amyloidosis have a markedly prolonged native T1 time, and this can help distinguish it from other causes of increased LV wall thickness. In general, the T1 time is increased when the myocardium has edema or fibrosis. From a practical perspective, we might be asking how long is prolonged and are there any cutoff values which can be helpful? And the answer is it depends. It depends on the scanner, both the manufacturer as well as the magnet strength and the sequence. So there are scanner and sequence specific cutoffs for native T1 times. For example, on a 1.5T magnet using the Schmally sequence, a time of more than 1,040 milliseconds has a diagnostic accuracy of 92% for cardiac amyloidosis, whereas on a 3T magnet with the Molly sequence, the average native T1 time in patients with cardiac amyloidosis is 1,438 milliseconds. Combining the native T1 and ECV values can help characterize the myocardial tissue. As you can see, there are a few cardiac conditions that have markedly prolonged T1 and markedly expanded ECV values other than cardiac amyloidosis. Prolonged native T2 time has also been identified. T2 time is typically prolonged when the myocardium is edematous, and this is very interesting, highlighting that there may be a potential inflammatory component to cardiac amyloidosis. When it comes to informing management in cardiac amyloidosis, we recognize that the subtype dictates disease-modifying treatments and that MRI and echo cannot reliably distinguish AL from ATTR amyloidosis, so other modalities and investigations are required. MRI parameters can be used to inform prognosis in cardiac amyloidosis, with many parameters being associated with increased mortality, including LGE, particularly if it's diffuse, and significantly abnormal ECV T1 and T2 times. There is an evolving role of cardiac MRI, particularly with ECV, to monitor response to therapy, which may become more important as more disease-modifying medications are used in patients with cardiac amyloid. Next, we'll review some of the findings of iron deposition. Although there are many underlying causes of cardiac iron overload, our goal is similar in all of these disease states, which is to identify cardiac iron overload as early as possible to escalate management and prevent progression. There are no specific findings on echo, so I'll focus on the MRI findings. Many of the MRI features of cardiac iron overload can be explained by the ferromagnetic properties of the iron that has deposited in the myocardium. So here on this SSFP sequence, the myocardium and liver appear hypointense. The T2 star time can be used to quantitate the amount of iron in the myocardium. Here on a midventricular slice, region of interest has been drawn on the septum, and the mean T2 star time is about 5 milliseconds, which is significantly abnormal and would suggest that this patient has significant cardiac iron overload. There are some technical issues with performing this sequence and its analysis, which have prompted investigations about other MRI parameters which may be useful to identify cardiac iron overload. A reduced T1 time has also been identified in patients with cardiac iron overload. And in comparing a reduced T1 time to a reduced T2 star time, preliminary investigations suggest that a reduced T1 time may be able to identify more patients with cardiac iron overload. However, most of the data informing management prognosis in patients with cardiac iron overload is based on T2 star times obtained on a 1.5T magnet. A cutoff of less than 20 milliseconds can identify patients where iron is depositing in the myocardium, and this may suggest a change in management to prevent further progression, such as initiation or escalation of chelators in patients with transfusion-dependent anemia. A cutoff of less than 10 milliseconds identifies patients who are at higher risk of heart failure, and a cutoff of less than 6 milliseconds was associated with almost 50% of patients having heart failure, as was the case in the patient that I presented with the T2 star time of about 5 milliseconds. And finally, we'll review some of the findings from multimodality imaging in Fabry disease. Fabry disease is an X-linked disorder that results in a deficiency or absence of alpha-galactosidase, leading to dysfunctional metabolism of sphingolipids. And from a cardiac perspective, this can lead to accumulation of fat in cardiac myocytes, although there can also be true myocyte hypertrophy and myocardial inflammation and fibrosis. Although Fabry disease is often listed as a secondary cause of restrictive cardiomyopathy, it's important to note that many of these patients do not go on to develop overt restrictive cardiomyopathy, although many do have diastolic dysfunction. And our goal here, again, is to try to identify cardiac involvement as early as possible to change management and prevent progression. Typical echo features in Fabry disease include a binary sign of the LV myocardium, and this is because the endocardium is thickened as a result of glycolipid-enriched smooth muscle cells, and then below it there's a subendocardial empty space containing free glycosphingolipids, and then an inner subendocardial layer of severely affected myocardium. Initial studies shows that this was prevalent in about 83% of patients with Fabry disease. However, subsequent studies only showed a prevalence of about 20%. Prominent papillary muscles are also described in patients with Fabry disease, although it has limited use in distinguishing from other causes of increased LV wall thickness. The longitudinal strain is typically reduced in the basal and infralateral wall. And on the strain curve, we can also appreciate a double peak with a postsystolic peak in addition to the usual systolic peak. And while this finding is typically associated with Fabry disease, the double peak sign may be present in any myocardial segment with fibrosis. Cardiac MRI typically identifies a globally reduced T1 time due to the accumulation of fat in the myocardium. However, as the disease progresses, patients may develop late gadolinium enhancement in a non-ischemic pattern in the basal inferior wall, corresponding with increased T1 and T2 times, suggesting that there may be a component of edema and inflammation in the disease process. Many of these imaging features inform the use of enzyme replacement therapy in this patient population. Imaging parameters can also be used to monitor response to enzyme replacement therapy. Notably, there has been a variable response in LV thickness and mass noted with enzyme replacement therapy. However, improvements in strain and T2 time have been reported. Importantly, late gadolinium enhancement and T1 have not yet been studied to monitor the response to therapy. In summary, we reviewed a multimodality approach to restrictive cardiomyopathies, highlighting the common imaging features that can be identified on multiple imaging modalities, including normal or increased LV and RV wall thickness, atrial enlargement, restrictive filling, diastolic hepatic vein reversal and inspiration, and plethora of the IVC and hepatic veins. Multimodality imaging can help distinguish amongst the secondary causes of restrictive cardiomyopathy. In amyloid, the 2019 expert consensus recommendations emphasize the use of the relapse ratio with abnormal value of more than 1, diffuse LGE, abnormal gadolinium kinetics, and an expanded ECV of more than 40%, in addition to increased LV wall thickness and diastolic dysfunction as features typical for diagnosis of cardiac amyloid. Additionally, we discussed the positive EF to GLS ratio of more than 4.1 on echo and prolonged T1 and T2 times on cardiac MRI. In iron, overload MRI parameters include hypointense myocardium and reduced T2 star and T1 times. In Fabry disease, there are many morphologic findings, including the binary sign and increased papillary muscles on echo, and on strain, decreased longitudinal strain, particularly in the basal inferior lateral wall, associated with a double peak curve. On MRI, initially there's a globally decreased T1 time, but over time, as disease progresses, we can see LGE and prolonged T1 and T2 times in the basal inferior lateral wall. As depicted in blue, many of these imaging findings can inform management of patients with restrictive cardiomyopathies. In patients with cardiac amyloidosis, the ECV value is emerging as an imaging factor that could be used to monitor response to therapy. In patients with cardiac iron overload, the T2 star time can be used to inform the chelation strategy, especially in patients with transfusion-dependent anemia. And in Fabry disease, there are many imaging parameters, which are criteria for initiation of enzyme replacement therapy and can be used to monitor the response to enzyme replacement therapy. As depicted with the underlying, some of these imaging features also inform prognosis. In cardiac amyloidosis, diffuse LGE and increased ECV, T1 and T2 times have been associated with increased mortality. And in cardiac iron overload, the T2 star time can predict the onset of clinical heart failure. And overall, I hope that over the past 20 minutes, I've emphasized how these imaging modalities can be used in a complementary fashion to diagnose and manage patients with restrictive cardiomyopathy. And with that, thank you very much for your attention, and I'd welcome any questions or comments at this time.